In this lecture, we're going to discuss orbital cellulitis and preseptal cellulitis. Basically, a child who comes in with an infected red eye. It's important to distinguish between these two things because we treat them differently. Bear with me here. Imagine, if you will, a bunch of firefighters around one of those old trampolines, and they're underneath the building and they're screaming, "Jump, jump," to the poor person who's up on the third floor who they want to save. Let's think about that trampoline they're holding. And let's imagine that we had this trampoline, but that center spot where the red dot is, we cut it out, so there's a little hole. So here's that trampoline with the little hole in it. Now let's drop a ball into the hole, but the ball is bigger than the hole, so it sits in place. There's the ball. This is essentially the eye. The ball is the eyeball, and the green part is the septum. And that septum is holding the eye in place, just like that ball is being held up. So here's a side view of an eyeball. That ocular septum, the orbital septum, is coming down and around the eye, and there's an extension so that that eye is firmly held into the head. However, that septum serves more than just a structural role. It prevents bacteria from going in one direction or the other. So infections in front of the septum will be different than the ones behind the septum. That septum is acting as a physical structure to hold the eye in place, but also a barrier for infectious organisms. So if we look at this eye again, infections outside the eye we call preseptal, or before the septum, cellulitis. These infections are mostly from the skin, and the number one organisms are staph and group A strep. However, if an infection is here, behind the septum, this is orbital cellulitis. And these infections don't come from the skin most commonly. Most commonly they come from the sinuses, because the sinuses are a paper-thin wall away from the orbit. So let's look then at the differences between these two infections. Orbital cellulitis is a mixed floral infection from the sinuses. It includes gram-positives, gram-negatives, and even anaerobes. And it requires broad-spectrum antibiotics to kill those bacteria. Also, there is a vision risk. This is an emergency. Preseptal cellulitis is usually group A or staph. We usually can treat it with narrow-spectrum antibiotics, like a first-generation cephalosporin. And it rarely spreads into the eye if we treat it correctly. So this 18-month-old is coming in to see you, and he has a swollen eye. How do I tell if it's preseptal cellulitis and I require only a narrow-spectrum first-generation cephalosporin, or it's a post-septal infection called orbital cellulitis, and I need broad-spectrum antibiotics, and I have to worry about this patient? How do I tell the difference? Well, there are a number of ways we can tell the difference. And here's all the symptoms and whether it's likely in preseptal or orbital. Orbital cellulitis can present with just about everything, but preseptal cellulitis, it's a little clearer. Let's look at these in two groups. In preseptal cellulitis, patients will have eyelid swelling, redness, and discharge. They can have that also in orbital cellulitis. And they will have a normal pupillary response, which is usually the case in orbital cellulitis, but certainly if you see an abnormal pupillary response, you should worry about that patient. But preseptal cellulitis does not present with diplopia, with abnormal eye movements, with pain with eye movements, or with proptosis. If you see any of these things, you should presume this is orbital cellulitis. So let's talk a little bit about diplopia. We need to understand where these sinuses are and why these patients with orbital cellulitis, but not preseptal cellulitis, get diplopia and pain with eye movements. So here's a little child who's presenting with a red eye. And this child has an infection of their ethmoid sinus. Remember that ethmoid sinus is just medial to the eye, which means that when that infection broke through that paper-thin bone, it entrapped the medial rectus muscle of this patient's eye. So now I'll ask this patient to look around. I ask them to look to the side towards their affected ethmoid sinus, they should be doing okay. But when I ask them to look away from the infected sinus, that infected medial rectus muscle is entrapped. They can't look out. So if I see a patient who looks like this, I can say very comfortably, this is probably an orbital cellulitis, and I'll bet you it's from an ethmoid sinusitis. Now here's a little boy coming to see us. He's also got a red eye, but this little boy has infection of his maxillary sinuses. So now this infection is going to escape upward into the inferior rectus muscle just below the eye. Let's have this boy look around. He can look to the left, right. He can look to the other side, right. He's doing okay with lateral movement. When we ask him to look down, he's fine. But when we ask him to look up, his inferior rectus muscle is entrapped and he has a disconjugate gaze. It hurts for him to look up, and you can see that his eye doesn't want to go that way.